when we're starting. I was just gonna see the members are still. Hi, we'll just start in about a minute. I just see a lot of people still logging in. Do you need any light? Can you see? All right, so I think that most people have probably gotten on, at least for the initial go. So welcome to the Together in Care advocacy campaign that's sponsored by TCAN with support from AAP Section of Neonatal Perinatal Medicine. It is my pleasure today to be able to host this webinar with Dr. Renee Boss. And so today we'll be talking about successful palliative care transitions from NICU to home. There is continuing education credit that's available for the live as well as the recorded sessions as well. And so if you're interested, there's a QR code at the bottom of the screen on this slide, but I'll have it at the end as well. And that way you can kind of register and get the CME credit. It's available to physicians, advanced practice providers, and nurses. There's also mock Part 2 credit available too. So today we're going to have a bit of a different format. So rather than having kind of a webinar with PowerPoint, we're actually going to do interview style. So I'm Cecilia Kwok. I'm a neonatologist at Johns Hopkins, and I will introduce Dr. Renee Boss, who I'll get to interview today. Dr. Boss is a highly respected neonatologist, pediatric palliative care physician, and bioethics expert at Johns Hopkins. She is a Rembrandt Foundation Professor of Pediatric Palliative Care, Professor of Neonatology, and core faculty at the Berman Institute of Bioethics at Hopkins. Dr. Boss has great expertise in neonatal palliative care, focusing on care for seriously ill infants and children, especially those with repeated and prolonged hospitalizations. Her scholarly interest and work focuses on improving clinician to parent communication, especially to optimize decision-making around medical technologies. And Dr. Boss also leads a Pediatric Chronic Critical Illness Collaborative, which is a multi-center effort expanding research in long-term pediatric critical care. And she's also a mentor and a colleague to many of us, as well as myself. I'm very fortunate about. So with the interview today, we're going to talk about these objectives that I won't go into detail, but really looking at how do you know when a baby might be ready for palliative care transition out of the NICU, what that looks like, and also what it looks like at home, whether a baby's on comfort care, hospice, or on other palliative care supports. I'm going to stop sharing my screen here. And we do want this to be as engaging and interactive as possible. So there'll be pauses. If you wanted to put any questions in the chat box or during the pauses, just feel free to add comments or questions as well. Dr. Pazadek is going to help monitor the chat discussion for us. All right, so the first big question is, how do you know when a baby is ready for palliative transition from the NICU? And what are some of those options and what could that look like?
Yeah, I think it sort of depends on the story, right? So if a baby is actively moving towards end of life and the family does not want the baby to die in the NICU, so that's a time obviously to think about it. And what would the options be? Well, perhaps there's another floor in your hospital, like a general peds floor that could make a homier environment and a calmer environment for the family. And so that might be an option. Maybe home hospice is an option, so going home with the support of hospice. Some places in the US, not as many as we would like, can do inpatient hospice for infants, so it sort of depends on the community. So that's in the scenario of a baby where they're moving towards end-of-life care. But other babies that, the question of when do you know that they're ready sort of for a palliative transition out of the NICU is, well, what are the goals? So if the baby is expected to live months to kind of indefinitely, but the family has a palliative outlook, meaning that they defer some perhaps surgical interventions or some technologies, and they really want to focus on as much quality time as the child can have, then when you reach that point of decision making where they say, actually, we've decided no to the surgery, or no to the feeding tube, or no to the whatever, and we want to see how much time we could have despite that, then that's the time to start thinking about, okay, what can we do at home?
And in those situations, would it typically be trying to get the baby home, or would there be other places to go as well that would not be in the NICU or ICU?
Yeah, so again, maybe there's another place in the hospital, would still be in the hospital, but maybe more family friendly environment, especially because some families who have been in the NICU for a long time really have a lot of trauma associated with being in an ICU environment. So sometimes even being in a general ward is less distressing to them. Maybe there's a local kind of pediatric rehab hospital that would be able and willing for the child to go there. Maybe you're lucky enough to live in a community where there's some kind of long-term care or medical home facility. Certainly there are some states that have some good options there. Otherwise, the option is largely home.
And this might be related to some of what you were saying already, but are there situations where babies can go home if families have these blended goals of care where they want some curative care, but they're also under kind of hospice?
Yeah, so we're lucky in pediatrics, at least still now, to have this concept of concurrent care, which is that insurances, some of them, many of them, will cover both palliative and or hospice care plus curative care. So a family doesn't have to forego curative care to enroll their child in hospice, but most families who are in that scenario of enrolling in hospice, but having some curative goals have, as you say, blended goals, meaning we want to treat acute infections. So if our baby gets pneumonia, we'd like the baby to come back to the hospital. But if their underlying condition is progressing, then we wouldn't want interventions for that. So they may want interventions up to and including intubation or pressors or even CPR. With caveats like we would want to try that maybe for a couple days. And then if at the end of those couple days, the medical teams could tell us that they think it's really the underlying illness as opposed to some sort of acute complication, then we would want to stop those things. So I think it's actually quite common that families have blended goals with babies that are going home, either in hospice or with palliative care.
And a big question that came up was, when should I refer to home hospice?
When should you refer to hospice or palliative care?
Hospice.
Hospice, yeah. So in the United States, the benefit, it's defined by an insurance benefit, which is largely 6 months. So if you can say that if the child's illness runs its natural course, that you anticipate that they would die within 6 months, then the insurance company generally will approve for hospice. I would say that, in the adult medicine world, most people enter hospice within 3 weeks of their death. And so that is a benefit that's very underutilized in the adult world. In the pediatrics world, it's often the opposite, meaning that some hospices will accept children who you're not sure if within 6 months, but maybe within a year. And then children can be recertified. So if a hospice enrolls a patient and then at the end of the 6 months, the child is still alive, but again, you would still say, but we would still guesstimate that in the next 6 months, the child would die, then the hospice can be recertified actually multiple times. And if in the wonderful case, as it happens not uncommonly, babies or children will graduate from hospice, meaning we all thought there was a good chance that when they went home that they would die within 6 months, but in fact they didn't, and maybe got better than we thought, or at least stabilized enough that the hospice will talk with the family about ending hospice, and the child would graduate from hospice, but then would be eligible to re-enter again if things got worse, and it's what the family wanted.
And often I think we're thinking about these things and maybe not at the same time the families are. So any thoughts about, when to start the communication with families and any tips on how to approach this with families?
Yeah. As a palliative, when I wear my palliative care hat, I would say the conversation is almost always too late. The ways that we have it now, meaning that I think it's very helpful to get the palliative care team involved early so that they can form relationships with families, because it's really continuity and trust and communication and relationship. That's a huge part of what I think palliative care can bring to the table for these families. So the earlier that the palliative care supports can start, then the earlier all of that stuff can start. And so when we reach a sort of decision tree where we can't extubate the baby, or we can't get the baby off high CPAP, or we can't feed the baby, or whatever it is, then the palliative team already is sort of a trusted group of people who can advise the family. So by and large, the answer is earlier than we're doing it now, to involve these kinds of conversations. But I also, keep my ear out for when the family starts to voice questions about how will we know if this is the right thing to do, or I'm not sure if I should put him through that, or he's been through so much already. So those sort of clues that a family who maybe even up until now has been, gung-ho, always wants every intervention, every option, is starting to kind of rethink what's important to them. So whenever you hear those sorts of phrases, that's a great time to sort of pause and say, there might be other options.
And are there, a lot of us are fortunate to have other interdisciplinary members as well. So if there's other kind of teams or folks that you think should be involved in when you're starting to have these discussions with the family. And
yeah. So, for those of you who are lucky enough to have a local palliative care team, you know that they are very much interdisciplinary, and so often include child life and social work and nursing, physician, music therapy, psychology, all sorts of flavors, depending on your local resources. One of the things that I would say is important for us to recognize in the NICU is that, many NICUs do a very good job of primary palliative care, meaning that every nurse and every doctor and every RT and every social worker who works in the NICU has some capacity to provide palliative care to patients. But when the baby leaves the NICU, those supports stop unless you've engaged another team or other people who can carry those on beyond the NICU. So that's another one of the advantages of getting the palliative care team involved early, is that it's a palliative care team who can follow the patient and family either home or to a different floor or to a different facility potentially, whereas all of the NICU supports end at the time that the NICU hospitalization ends.
And then this was a question that came up from the audience, but the question is, what should I order for a standard end of life care comfort pack? And maybe for someone like me to understand, what does that mean? Like, what is an end of life?
Yeah, that's a great question, and in part depends on what your resources are. So if you're lucky enough to have a local pediatric hospice, then you should talk with them about what they would recommend that you order, because they're going to primarily assume responsibility for those things. And so a comfort pack is often doses of morphine, doses of a benzo, maybe doses of an antiemetic, maybe doses of seizure medication, things that are predictably going to be helpful to this baby at home as they approach the end of life. So if you have a local hospice that you work with, then I would say talk with them, because they're the ones who are going to have to basically carry out whatever orders you give. If you don't have a local hospice, then you need a pediatrician or someone in the community who you're going to be working with, who again is willing to assume responsibility for those orders, because you're not going to keep, you're going to write them potentially, but you're not going to be responsible for them once the child is discharged. So I would say that in general, the sort of comfort packet is something like an opiate and a benzo and maybe a seizure medicine and maybe some GI medicine. And ideally, it's something that you do in coordination with whomever is going to take the responsibility for that. But the idea, just for those of you who haven't heard the term before, the idea is that the family would have some medications potentially in the home, that if they, in the middle of the night, called the hospice team or the pediatrician and said, oh my gosh, the baby looks really, really uncomfortable and really worried, you could say, okay, then whoever the outpatient person is responsible would say, okay, give them the morphine or give them the benzo, rather than having to wait to get those medications delivered, because so many of these medications are controlled.
So then, I mean, in that setting, would you recommend if there is not a palliative care team that really starting the planning with a pediatrician much in advance the baby? That's a lot of responsibility.
It is a lot of responsibility, and there are a number of pediatricians who quite understandably don't feel comfortable doing it. And so it's an important conversation as well, because the answer may be there is no one in the community who is willing to take this on, in which case you really do need to figure out another way to do this that doesn't involve going home.
I think that's a lot of the questions that we had in terms of really starting the discussion with the families and for the medical teams thinking about preparing for this discharge to hospice or to home. I don't know if there's other questions that have come up from the audience.
There was a question that asked, what does home hospice care actually look like when at home?
Yeah, thanks for asking. I would say for me, one of the very best things that it looks like is 24/7 phone access, typically to a hospice nurse or a hospice physician. That can be the first call for families. So they don't have to call their pediatrician. They don't have to take a baby to the ER. If they are worried about the baby, they've got the hospice people who know the story, who know the situation. They can call and say, this is what's going on. What should I do? And sometimes the answer is that the family wants to take the kid to the ER, in which case the hospice team will say, then go ahead and go to the ER, call me when you get there. So often the hospice team will then talk to the ER doctors about what's going on, etc. So 24/7 phone advice from people who understand what's happening and are not going to freak out. It is a really important advantage that many families find almost the most important thing. In addition, it involves some visits from nurses, typically, some visits from social workers, sometimes child life, sometimes chaplain. Each hospice also has different people involved on their team. And the intensity of those services varies with the intensity of the situation. So for a child who's going home on hospice, but really we expect the end of life is really going to be in the order of months, then the in-home visits by hospice may just be weekly for a while. But as or if the child's needs increase, then the hospice visits increase, and maybe daily, maybe for several hours daily during the most intense needs. But it is important to understand that much of the care that is delivered to a patient in hospice is delivered on the part of the family. And so an important factor to consider when you're thinking about home hospice is, does this family have enough people in it that they can, deliver the 24/7 care that still by and large is going to fall to them.
Were there any other questions that have come up as well?
Not at this time, no.
So I think there were some questions about kind of the logistics around discharging to hospice. The first one was, do you need to send hospice comfort care patients home with a DNR, or does a hospice agency do that?
So most hospices will accept a pediatric patient without a DNR. That being said, most hospices will actively engage with families about obtaining a DNR. So it's not a requisite. It is not required really anytime that they are in hospice for most hospices. But it is, as part of a goal of care, it is a sign that a family hasn't quite fully processed maybe what's most important to them. And so they will revisit the conversation in the context, not necessarily getting the form signed, but helping them understand that if they've chosen to take a child home in the hopes of maximizing quality of life for however long there is, and of keeping the experience very family-centric, then getting CPR is potentially going to put the child back in the situation that they just left, in the ICU, intubated, etc. And so often hospices, that's the piece that hospices will work on, is helping families understand how these decisions about CPR, DNR, etc. are potentially putting them back in a situation that they're already wanting to leave.
Excellent. We have one more question. What other members of the hospice team exist besides a doctor and a nurse? Also, how do you describe hospice support to a family?
Yeah. So again, hospices have different members depending on where they are. So physicians, nurses, social workers, chaplains, child life are, I would say, the most common. They may have music therapists, they may have art therapists. All hospices have to have volunteers, and so that actually can be also be a really nice source of support for families. Volunteers from the hospice can come and do things like laundry or you know, helping to do some things around the house or helping to run errands or things. So that can be logistically very helpful. And then in terms of the, you know, how do you introduce the conversation about hospice, I would say that it's best done in the midst of an important conversation with families about goals of care. And if their goals of care are to go home and be in the hospital as little as possible, then there's this great group of people that can provide you home support. Have you heard of hospice? Now, plenty of people have baggage about hospice. Plenty of people had baggage about palliative care. Maybe they went through something with their parents or their grandparents, and so it's good to just get that out. If they have experienced hospice with adults, one of the first things I talk about is how very different hospice for adults is for hospice for children. Again, hospice for adults is typically truly end-of-life care. Adult patients who go into hospice are typically in the active dying phase in those last couple weeks of life. Whereas babies that go into hospice, maybe in hospice, we take care of patients who have been in hospice for 2 years. So it's a very different experience. So making sure that you're unearthing whatever preconceived notions people have about hospice so that you can sort of address them, and really talking about the added layers of support that they can get in the home that can help them have fewer doctor's visits, fewer ER visits, fewer times back to the hospital, and that 24/7 phone support.
Are there ways, I mean, I think in terms of, you mentioned trying to really understand what their goals of care are, the family's goals of care, and I feel like it's something that's hard to say, what are your goals of care? And they don't know. But any, thoughts about how, I think you often have just great language about how you approach families or things that you might say to kind of elicit some of that.
Yeah, I appreciate that. And it is an important point to make that goals of care, while those are simple words, they are jargon. And the average person on the street does not have a goal of care, right? We as clinicians understand goals of care, but families do not understand that language. And so we should never really be using that language with families because they don't quite know what it means. So I use phrases like, what's most important to you? What are you most hoping for? What are you most hoping to avoid? What sorts of things might you regret? That sort of language to sort of get a sense. And when you say, what are you most hoping for? And the most common answer will be that, she'll get better.
Mm-hmm.
I hear you. What else are you hoping for? And they say, well, maybe that her, she'll be more comfortable. Great. What else are you hoping for? And usually if you can do that a few times, people can start to get down to things that are a little more doable than the idea of, I hope that there will be, something that we all don't expect to happen, which is that suddenly she'll just get better.
So I think, there were a lot of questions about the hospice experience at home, which I think some have come up already. But in terms of, you talked about the makeup of a hospice team, do they themselves provide home nursing or do they connect to home nursing somehow?
Yeah, so they don't really provide home nursing in the way that we typically think about it, like, daily going into the house and giving a medication or managing a ventilator at home. So they're not shift duty nurses. And they're not the kind of nurses that go and check on babies, maybe 3 times after they leave the hospital with a G-tube or something. They are nurses that will make intermittent visits to the home. And they may deliver medications, they may draw labs. So sometimes a hospice, if you, for instance, are sending a baby home on a medication that needs levels checked in order to be safe or needs electrolytes checked in order to to be safe, you, with good communication, might be able to work out an arrangement where the home hospice would be able to do that. But there is also the possibility, depending on your state, depending on the insurance, that the child may be eligible to get both home nursing as well as hospice. So a situation could be if they need duty nursing for a home ventilator, but they're also in hospice. There may be ways to work that out, but these situations where you want to overlap services, I can't emphasize how important it is to figure out the insurance piece as well as the just like community resource piece really early before you offer that to a family, because sometimes those things are a no-go.
And I think you had already talked about really how it sounds like the hospice team spends the amount of time with them depending on what the family's needs are in terms of how often they come and how long they're there.
Yeah.
Do they typically just their support is like in the moment, so what the family needs at that time? Do they do some planning with the family as well when they have their intermittent visits?
Yeah, all those things. So for sure, addressing acute things, symptom management. So symptom management is huge. How is the baby doing? Do any medications need to be changed? Do the feedings need to be changed? Is there something acute going on? So is the family noticing, is the visit because the family said she just seems different today, and so the nurse came today as opposed to, when they were scheduled later in the week, and then nurse will do an assessment about, is there value to going to the pediatrician or going to the ER again? If it's just a UTI, would the family want to treat it? Yes, they'd want to treat it. Well, then they need to go get evaluated for a UTI. So we'll help make those sorts of things. So symptom management and acute care, but very much also planning. What's important, given where we're at now, we've seen him settle into being at home. You now know what it's like to have him at home. Are there adjustments that we think we should make to the routine and the plan? Is the child doing better than we expect? And would it make sense now to go ahead and see the neurologist and think about maybe titrating the seizure meds? Or would it make sense to see the GI doctor and think about a higher calorie formula, et cetera? As well as the conversations I pointed out about, so if you were to get really sick again, you previously said you would like him to go back to the hospital. Is that sort of still where you guys are at or not? And then also sort of, other kind of out the box thinking about, is there a family trip that you want to go on? And, we have families that want to go to Disney. Well, okay, the hospice can, there are networks around the country, probably internationally, but I mostly know the ones around the country where if you're going to Disney, there are places and clinicians and teams that are used to getting kids there who are coming for sort of Make-A-Wish type visits. And so the hospice can also help network and find out if the family wants to do something, go on a family reunion or do something that's important to them. The hospice can try to help figure out how to make that happen.
So that's a lot of coordination. I guess my assumption or thinking is that is it a pediatrician that's kind of the lead on the hospice team? And if that's the case, what if there is no pediatrician on the hospice team?
Yeah, so it can go either of two ways. So one possibility when a baby leaves the NICU on hospice is that a hospice physician will become the physician of record, meaning the primary physician outpatient responsible for that child. I think that situation is ideal when we anticipate that the end of life is going to be fairly quick. So a week or 2 weeks, much too quick for a new pediatrician to get involved in the story and sort of take over. But if we think a child is potentially going to live months, there is good reason for them to have a pediatrician as well, because just because a child has a serious illness doesn't mean they're not also going to get serious diaper rashes and ear infections. And some families do decide that they want vaccines. Some families do decide that they want subspecialty follow-ups because there's often there's some window of uncertainty about how this is going to go. And so I think, again, if we think the end of life is going to be quick, then not involving the middleman of another pediatric provider is probably wise. But if we think the baby is going to survive months, then it makes perfect sense to have a pediatrician be the physician of record.
I think this actually gets kind of to this question was how a hospice agency could be helpful if the patient is not going home on comfort care. And maybe that would be the type of situation that you just mentioned.
Yeah.
It could be a much longer time than we thought about a couple of weeks.
Right. So, again, you really just have to, in order to certify for hospice, it's really a insurance definition, this definition of 6 months, but it's an insurance definition. If, if you're going to discharge a patient into hospice, if you, Dr. Kwok, are going to enroll your patient in hospice, you may be asked to sign a form that says, to the best of my medical knowledge, if this child's illness runs its natural course, I believe that they are likely to die within 6 months. So again, months is how long a patient may be in hospice. And many children are in hospice for months.
Do you think there is a population of children who would not qualify for hospice, but were followed by palliative care and could still use a lot of these supports and what's available to them?
Yeah. Yes, so that's a great question. So there is, I would say, a growing access throughout the US to outpatient pediatric palliative care. It's still not nearly as common as inpatient pediatric palliative care, which is still not everywhere. So again, it's about the community resources. There are some hospices that do actually also have a palliative care arm. So when you refer to a hospice, if the child doesn't meet criteria for hospice enrollment, they may meet criteria to be followed by the hospice's outpatient palliative care team. Some inpatient programs have outpatient pediatric palliative care as well. So if you're lucky enough to be in a community where outpatient palliative care is available, then the number of kids eligible for that is huge, right? So virtually any of the kids who are leaving the NICU with complex chronic issues, feeding tubes, serious respiratory support, multi-organ conditions with complications and lines and medications and many subspecialists. So kids who are going to have a complex course, especially if the family has an overarching value about, we want to try these things, but we also know there might be a time when it's too much. And so I think for families who say, we've bought all in to all of this, or at least we've bought into however much we've done now, but we would really value having longitudinal discussions about goals of care where we reevaluate, well, how is that feeding tube going? Or how well are the seizures controlled? Or, is he starting to be more alert? If we can sort of reevaluate on a every couple month basis with someone, how that's going and how that might change how we're feeling about ultimately going forward with the surgery at 2 years or whatever it is, that's a great space for the palliative care team as well.
I'm going to take a quick pause because there's some more specific questions to see if other ones had come up.
Oh, we do have another question that came up. What happens if a family does not have insurance or is in a resource limited setting? Are there any resources that providers can use to help babies get the hospice care they need and the family wants?
Yeah, great question. So, the concurrent care benefit really is about Medicaid. And so if the family can qualify, then they should be able to get it through that. I would say that we have had success in our community of getting basically free care from pediatric hospices in situations where there really weren't insurance coverage options. And so I think that, for me, it's interesting. One of the very heartening things about being a pediatric palliative care physician is that I do get a front row seat to people stepping up in the community and trying to meet needs. And so I think it's not uncommon. And I guess maybe what I should say is I would encourage you to reach out to your local hospices if you have a situation where a family would really benefit from hospice or palliative care. Insurance is clearly the barrier, and just try to see, are there options? Are there ways? Because I think a number of hospices have some funds set aside for essentially charity care. They're only going to use that if we reach out and tell them we have a situation that would really benefit from that.
Excellent, thank you. That we don't have any other questions in the chat at this time.
Okay. So these are some specific ones. One was, what do you need to know when sending a hospice patient home by, I think, family, kind of going home with family, like in family transportation versus going by ambulance? And how do you dictate one versus the other?
Yeah. So in general, the child would go home in the family car and with family transportation, the way any other NICU baby would go home. The times that is different is if you are going home. So there are times when we have utilized local hospice to do compassionate extubation in the home. And so that baby goes home in an ambulance. And often a provider from the NICU will go in the ambulance and be the provider of record during the transport. And then when you get to the home, you will transfer care to the hospice team. So the hospice team is typically there waiting. The hospice physician is typically there waiting and ready to sort of assume care. And typically what happens is that you extubate the child while the NICU team and the transport team essentially is there, and then the transport team leaves, and then the hospice stays and manages care. So that's a scenario that if you haven't already done that in your institution, and even if your NICU hasn't done it, it's possible your PICU has done it. But if you haven't done it in your institution, but you think it's a good idea, then I would encourage you to do very much preemptive planning and protocolizing for that, because it involves a lot of moving parts, a lot of pieces that are unfamiliar to people. It requires, a great thought about where the medicines come from, and the, pharmacy and drips. And so there's a lot of moving pieces, and there are some published protocols out there for that can help guide you. So there are some situations where the only way that transport could happen, obviously, is with an ambulance. We have had some more gray zone transports where a family didn't feel comfortable bringing a child in their car. Technically, the child didn't really necessarily qualify for an ambulance, but again, that may be a situation where if the insurance company won't cover the ambulance ride, where either the hospice or the hospital might be willing to cover that ambulance ride so that you could get the baby home.
We do have one question regarding transport home. What happens if a patient dies during transport home, or let's say on arrival home when a family is driving?
Yeah, great question. And that is always something that has to be talked about when you're going in this situation, is to talk about the possibility that the child could die during the transport. So you just have to be upfront that this is a possibility that could happen. And this is the part where some families, want help, want to go home in ambulance. So yes, it can happen. It's always disclosed. I have been doing this for 20 years. I've never had this happen in the 20 years that I've been doing it. So it's not super common that it happens. I think if a child is truly so moribund that they're going to die in a 1 hour drive, then I would question whether going home is really the right thing to do. And I have been in situations where, it's Friday and we say, okay, we're going to plan for Monday to go home, and we get everything, the protocol and the transport team, and get everything ready for Monday morning. And then Sunday night, it becomes clear that the baby is declining. And so I will pause and say to the family, I think it might be better if we just stay here and make the best experience that we can for your family here, because I am worried that if he gets in a car, seat, that he could die during the transport. So it is an important thing that needs to be explicitly talked about.
So another question was, if there's a patient who goes home on hospice care, can they change their mind and be readmitted to the hospital? Or does going home on hospice mean that they can't come back to the hospital?
Great. So again, with concurrent care, and not all insurances approve in concurrent care, by the way, but with concurrent care, all of that is fully covered. So, you know, no hospice will ever, in any situation, tell a family that they can't go back to the ER or can't go back to the hospital. So if a family's gone home on hospice and the plan is 100% for hospice and never going back to the hospital, but in the middle of the night, when it comes down to it, the family just can't do it, and they say, we're going to take him to the ER, the hospice is going to say, go. And so they'll go to the hospital, get through whatever acute situation potentially. And then if we reach another point where maybe the child could be discharged again, that's a good time to sort of revisit. Okay, so you came back to the hospital this time. Does going home with hospice still make sense for you, or have you like totally changed your goals? Most families will say, no, we still want to go home with hospice, but some families will actually say, no, actually, we've changed our goals. We realized once we got home and once we went through this experience that actually it doesn't match what we want, and we'll change. And hospices, you know, will gladly discharge a patient from hospice if that's truly what the family wants. But so absolutely, if a child goes home on hospice, the family always has the ability to bring them back to the hospital. It doesn't mean that they won't stay enrolled in hospice, but it does mean we need to revisit the conversation just to be sure that everybody's on the same page.
Opportunity to do that. Thinking about concurrent care, so is early intervention developmental follow-up appropriate after discharge for babies if they have an unknown life expectancy?
I would say in general, yes. You know, I think that early in my career doing this, I was on the side of trying to protect families from unnecessary visits or, you know, going to the doctor more than they needed to. I really had the vision of, you know, we should be promoting quality of life at home. This family wants to be home, and so I shouldn't schedule a bunch of stuff like vaccines and, you know, regular checkups that will detract from the family's experience. And I would say that I've sort of swung, I guess, the pendulum, and maybe that's because I've by this point had enough babies that surprised me how long they lived. And so I thought they might die within a month, but 5 months later they're alive. And I think that the danger of not setting up the appointments is that sometimes the sort of general peds care for these kids can fall through the cracks a little bit. If it wasn't set up by the NICU, right? So if there wasn't a plan from the NICU to go ahead and make the appointment with the neurologist or the pulmonologist or the whatever, sometimes those will fall through the cracks. And so I've personally swung to the side of talk with the family. If they're on the fence a bit and they might like the appointments, I schedule the appointments, and then I tell them, and you can always cancel them. So you can always cancel them. But I will say in terms of things like therapy, like physical therapy and developmental follow-up, you know, I would say don't underestimate actually the benefit that those therapies have to quality of life, in the sense that those kinds of therapies often give families something to do. And families really love something to do that is about making their baby feel better or be as alert as they can be or be as comfortable as they can be. So in terms of the specific like developmental physical therapy stuff, I would say I think that families do get some quality of life benefit out of that, sometimes maybe more than the visit to the pulmonologist or whatever, frankly. But anyway, so I think the danger in not scheduling things is that if the baby lives longer than you think they will, some of that stuff could fall through the cracks because people in the community are so used to the NICU scheduling that stuff that if it doesn't get scheduled from the get-go, it may not get scheduled. There's always the opportunity to tell the family, but any appointment that comes up that you don't want to go to, just don't go to it.
Yeah, that makes sense, and especially because it's a lot for a pediatrician, and especially if they don't know what they need to be scheduling. Somewhat similar but different, there was a question about navigating state screens, including newborn screens, especially if parents had elected for no No blood draws.
Yeah. That one I guess I would say is kind of on a person by person basis. I think that if if a family is choosing no painful procedures, period, and we think that the baby is likely to have a very short lifespan, then there's absolutely no reason to do no more screening. So that one's easy to me. I think the harder one is for a family who says that they don't want painful procedures, but there's every chance that this baby could actually live a prolonged time. And so I take care of a patient as a palliative care doctor who's now 7, who I was in this exact situation with. I was also the neonatologist when this baby was born, and the family wanted no painful procedures, and they like literally nothing, no glucose checks, no nothing. And we agreed to it, and then it's 7 years later. So it's hard to predict, I guess, what's gonna come forward. But if you really think that the time is short, then that's super easy. Of course, you shouldn't do newborn screens. If you think the time could be longer, then I would say it's worth having a conversation with the family about it and about what the potential pros and cons would be of doing it and not doing it.
And this is the last question that I have, and I don't quite understand it, but how to support the families with empty arms in the way back.
So I think that's the question about sort of bereavement support for families who are leaving the NICU after a baby dies, is what I'm going to interpret that as. And again, if you're lucky enough to be in a center that has a palliative care team, you may be lucky enough that they have resources to do longitudinal bereavement support. So some places will do bereavement support for up to 2 years for families. Many hospices as well do bereavement support for up to 2 years. And some hospices in some communities will provide bereavement services to families whose children were never enrolled in their hospice. So they may provide those as a separate option, just bereavement care for families. So you can look for those services. I think just asking the question, how do I support a family in this situation, tells me that it comes from a place of awareness of what it's going to be like for the family to leave the hospital without a baby. And so that tells me that a good and caring clinician wrote that question, and I suspect is already at least part of the way down the pathway of figuring out how to support families, because truly recognizing the loss and recognizing the lived experience of it is often very much welcomed by families and very appreciated by families when we can think about those things. I will say that as part of program building, we have done things here of thinking about, one of the things that a parent told us was after they left the NICU and their baby died, they went to the parking garage and had to pay for parking. And that was, it just felt cold and uncaring on the part of the hospital that we would be charging them for parking when they were coming. And so we got that feedback. And so then we applied for a small grant and we got some money so that our palliative care team, anytime a family is leaving the hospital in this situation, we're at least able to pay for their parking that day, et cetera. So I guess my point being, there are some services out there in the community. Your palliative care team may have some services. As for the moment of sending them from the NICU, I think that the most important thing you can do is to acknowledge that this is a really hard thing, that that they're about to go get in their car, they're about to drive away from the NICU for the last time, they're about to go home, for the last time, really knowing that this is what's happening, and just acknowledging that and telling people how hard that is going to be, and how much you'll be thinking about them, and is just that human connection, I think, can be very, very important.
We have 2 more questions in the chat. The first one is, as the NICU or palliative team who transfers a patient to hospice care and is no longer the physician of record, do you have a practice for continuing to communicate with the family for support for bereavement purposes, or to continue the social psychological aspects of palliative care?
Yeah, great. So again, I think one of the sad parts about neonatology is that our care often stops when they leave our doors. And so as a neonatologist, largely the answer is no. There are members of the NICU team that will sometimes social work or case management or chaplain that may continue, but I think, as you undoubtedly are aware, there are some nurses and some doctors and maybe some RTs, individuals who may stay connected to a family through social media, et cetera. On the palliative care team, that's a bit of a different deal. So I think that most palliative care teams have built in some connection ongoing with families. And depending on resources, again, that connection may stay for 2 years, where some programs provide like support groups, family support groups, sibling support groups, grandparent support groups. Many places do annual tribute services where anyone who's ever had a child die in the hospital is invited. People, some programs will send holiday cards or anniversary of death cards. Some programs have additional supports for families who become pregnant again, because that can often be a reawakening of some of the trauma. And so some bereavement programs have services specifically dedicated to that. So it's mostly based on sort of what's available in your community, but largely it will probably come through the palliative care services and probably less through the NICU services. Although I'd be thrilled to hear that there are a bunch of NICUs out there who are doing longitudinal bereavement. I just don't know of them.
Thank you. And then is there a listserv or group of people dedicated to peds palliative or hospice care?
I'm not sure I fully understand the question. What I would say is nationally, there certainly are, you can Google, where are the pediatric hospices across the country, and there are websites that list basically all of them. You can also Google where are the peds palliative care programs across the country. I would say that not all peds palliative care programs are created equal, in the sense that some hospitals will list on their website that they have a pediatric palliative care program when really it's like one part-time person, but it's listed as a program just as much as another hospital who has a program with like 6 physicians and 7 nurse practitioners. And so that's a little unsatisfying when you do it the Google way. The American Academy of Hospice and Palliative Medicine, which is basically the AAP of palliative care, it has good resources on its site of where the programs are and where the providers are. So hopefully I understood.
I guess a better way to probably ask it is there like a network? So all of the palliative care programs in the country, those physicians, is there like an email group of those physicians that that are all connected, so it would be easy to contact many faculty at one time, maybe for asking advice, for example?
Okay, thank you for helping me. Yeah, so actually the AAP, so the section on hospice and palliative medicine, it is part of the AAP. So just like, any of the other perinatal groups, et cetera, is probably the listserv that I most see used in that way. Questions, I have a patient with X, has anyone had experience using gabapentin in this situation at home for patients, with this sort of babies with this sort of irritability, et cetera. So yes, the section of hospice and palliative medicine through the AHPM is probably the most robust type of listserv like that.
Excellent, thank you. That is all the questions we have in the chat, but it looks like we're coming up on our time soon as well.
So let me just put this last slide here on as we are ending, if I can do it. So I just want to say thank you to Dr. Boss. I mean, we have a fantastic pediatric palliative care program, and I still learned a lot today. And thank you for everybody who submitted questions too. I think it was like really insightful just to hear what the different practices are, and really to like have some kind of space and time to really think about this, versus when you're doing it in the unit, you don't have that space and time. So I have here, this is, if you want to register to get CME credits, I have the QR code here, as well as the mock part 2 questions. It has a CME code. And let me just show you the next slide for a second. I think I mixed up, but the next webinar is on August 12th with Dr. Brady, thinking about providing thoughtful redirection of care. So you can register and you should be getting emails as well. Let me go back to here so that anybody who hasn't gotten it yet could do the CME code. Otherwise, thank you guys so much for joining, and hopefully it was a really good, insightful session for everyone.
Thanks everybody for being here.